Good afternoon, everyone. ITECH welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is issues related to access to care for key population injecting drug users, and speaker is Mr. Charanjit Sharma. Mr. Sharma is currently working as Technical Advisor, Drug Use and Harm Reduction at India HIV/AIDS Alliance in New Delhi. He is also the Secretary of the Indian Drug User Forum. He brings nearly 2 decades of professional experience in the fields of drug use, HIV/AIDS, and human rights of people who inject drugs. He joined Alliance India in 2011 and has been spearheading various programs on harm reduction. He is ardently working as a part of the global harm reduction movement of the International HIV/AIDS Alliance and its consortium partners, the Asian Network of People Who Use Drugs and the Indian Drug Users Forum. We welcome you, sir, for today's NDLS session. I would request Mr. Sharma.
Hi, this is Charan. Good afternoon to everyone. Okay, I'll take you through the sessions, and today we are going to discuss about the drug use, injecting drug use scenario in India, and what support or care they require from various other programs, not just related with TI. I'll be also talking a little bit about TI, but then how do we coordinate with various other service outlets, for example, like ICTC, ART, tuberculosis, various other, for example, like hepatitis C is one of the emerging issues among injecting drug users in India. Okay, so as you all know that today the session would be more on sensitization of healthcare providers to improve access to care for key population, which in the terms of NACO, we also refer them to as HRG, high risk group. But the universal accepted term for the people that I would be talking about is normally referred to as people who inject drugs or people who use drugs. So the following sessions we would be talking about, understanding the various risk factor exposure among people who inject drugs, or in TI term we call it injecting drug user. So I have mentioned in advance that the more universal term that we use all across the world is people who inject drugs. But for your convenience, I would be also using the term injecting drug users, or IDU, as per our national program. So in this session, we would focus more on the need of providing service which is stigma-free or stigma-less HIV prevention, that is mostly given at the targeted intervention level. We will be talking about care and support, which when someone is infected with HIV, how do we link it up with the care and support center, and treatment at various levels. It could be at the ICTC, it could be at the ART, it could be at the tuberculosis outlets. Yeah, as you all know that there are 4 targeted groups, or what we call it key population, that is people who inject drugs, or people who use drugs, or injecting drug user, male sex worker, or we refer it to FSW, MSM, people who have sex with same sex, transgender women, and Hijaras. But most importantly, what we need to remember from this session and what we would be discussing is, first, they are human being, and later on what people choose or what people want or what people is their choice of to be falling in these different categories of different high risk group or key population according to the National AIDS Control Program, NSCP. In India, we have an official estimation of 1,77,000 injecting drug user population. This is official, but we have been having discussion with the national program, and we also have been discussing among the civil society, among the networks of people who use drugs or networks of people living with HIV, that this estimate could be lower. It could, it would be higher than 1,77,000. We are so, but as long as we don't have an official information or data, we have to go by this number. And as per the national guideline, a person who has injected at least once through injecting route in the 3 months, the definition of injecting drug use or people who inject drug falls into the NACO guideline, and they can be registered and avail service from the targeted intervention. So according to the national report, we have covered around 1,28,000, almost 1,29,000, that's 72% of the total population of 1,77,000 through needle syringe exchange program and the oral substitution therapy. I think most of you are aware of oral substitution therapy. If you are not aware, I would be happy to respond to that. So we have oral substitution therapy that is been provided at the government as well as at the NGO run OSA center, and the medication is called buprenorphine. We have another OST which is called methadone that has been provided from 5 hospitals across the country. So the number of buprenorphine outlet and number of methadone all together, it would be about roughly about 170 centers across the country. I'll also come to that figure later on when we talk about the numbers. And the most worrying part among all the HRGs or among all the key population is that if you look at the prevalence of HIV among this key population, IDU is the highest. That is 9.9 according to NACO's report of 2015. So if you're looking at this slide, you can just look at the comparison of HIV prevalence among different high-risk group. 2010-11, when the study was done, it was about 7.14%. But then if you look at the 2014-15 IBBS report of NACO, it is 9.90. We can almost say 10%. So 10% is an alarming prevalence among the key population. Once it crosses 5%, then it becomes alarming for all the key population. But then if you're looking at this particular figure, we have the highest among the injecting drug using population. I would also talk about why the prevalence among injecting drug using population is higher than most of the other high risk group or the ANC. Yeah. So The drug use response in the country, um, we have started this program by different donor agency as well as by the National AIDS Control Society in early 90s itself. The program became more stronger. The program design was more focused on particular HRG. Later on, as we kept on learning about different HRGs or the different key population groups in the country, and if you look at the TIs that are being implemented across the country, which is about 247 or about almost 250 IDU TIs are there across the country, and out of this, we in India we implement 8 of the 9 components recommended by the global um, organizations like WHO, UNAIDS, UNODC. So WHO, UNAIDS, UNODC have recommended 9 components that should be there in a TI if you're working with injecting drug using population. But it has been revised very recently, and this component has increased to 10. And out of this 10, in India, with the targeted intervention, we are implementing 9 components. I would come to those components in the later slide when we talk more about injecting drug using population. But the most important thing is that when we are working with people who inject drug or injecting drug user, we should not forget that we should also be working with their partners, with their spouses, with their families. Until and unless we do not work with their partner and their spouses as well as the family, our intervention efforts would not be successful up to a certain level where we would want to see the response in the country. Though we are implementing almost all the components, almost 9 components of the intervention, there are some gaps in the program. For example, addressing overdose or addressing hepatitis C infection. It could be a mono infection or it could be co-infection. So this slide talks about the National Harm Reduction Strategy adopted by the National AIDS Control Organization, implemented through the State AIDS Control Society, who further provides funding to the NGOs, which we call it targeted intervention. So the components that we have talked about earlier is community-led outreach service to both male as well as female injecting drug users. Female injecting drug users at the moment is only limited to the northeastern part of the country. We do not have a separate targeted intervention for female in other parts of the country at the moment, but we have about 7 female IDU TIs in the Northeast, but we are yet to scale this up in other parts of the country. We have drop-in center, where it's a center where an IDU can walk in, a family can walk in, or there are different other services that is available in the drop-in center. It could be a recreation, it could be, some drop-in centers have carom boards, some drop-in centers have different other facilities of playing games, so that when people come to the drop-in center, they should not be just sitting idly. Drop-in center is also a place where the service providers, the outreach workers, the peer educators, or the nurse or the counselor can take advantage of people coming into the drop-in center to organize different sessions on how injecting drug using population can reduce um, or can prevent HIV as well as Hep C while they are while they continue to still inject drugs. I've already talked about buprenorphine. This is available both in the government as well as in the NGO run NGO run centers. So we have about 48 to 50 NGO who is implementing this program, providing buprenorphine. The remaining about 110 or 120 is actually a government-run OSC center, which we call it, government TI model, where the government centers provide this buprenorphine, and the TI have to refer people to the government center. Um, then we have this behavior change communication. Behavior change communication is an important component of the targeted intervention because we have to kind of study the behavior of people who we are dealing with, whether it is injecting drug user, or whether it is a female sex worker, or whether it is MSM, whether it's transgender. Until and unless we don't understand their behavior, it is very difficult for us to design, or it is very difficult for us to um, plan our activities of reaching them out. In TIs, it is also essential that we should have IEC material. IEC is information, education, and communication. There are a couple of IECs that are available in some of the drop-in centers, but all the drop-in centers do not have this adequate number of IEC that they need to be having in their drop-in center. And also it is important that the IEC material is in the local language. For example, if I talk about UP or Delhi, it is good to have IEC material in Hindi. If I'm talking about more of the northeastern part of the country, like Manipur, Nagaland, Mizoram, it is good to have IEC material in English. So the IEC material when I am talking about IEC materials, IEC material could be about safer injecting. IEC materials could be about safer sexual practice. IEC material could be about OST, how to take OST and how to retain in the program. IEC material could be about ART medication. So it does not limit to certain practice. We could think of various other requirements of the population that we work with, of what kind of IEC that we need to develop. NSEP, or now if you see the new terms, you would in the NACO guideline, you would also start seeing NSP, because we are trying to do away with the exchange. At the moment, we call it needle syringe exchange program, but now we are trying to call it as needle syringe program, because when the word exchange come in, some of the TIs who are new or who do not understand the needle syringe program properly kind of enforces or kind of make it a compulsory for injecting drug using population to bring in all needle and syringes, and until and unless they don't bring in all or use needle and syringes, they don't give out new needle and syringes. So it is kind of an exchange. I bring in all syringes and you give me new syringes. But then that concept is it's evolving. It is important that we need to collect the used and the contaminated needle and syringe from the circulation among the injecting drug using population. But then that should not just be the criteria of giving needle and syringes. We should provide needle and syringes to anyone who requires it, whether they return it or not, or whether they bring all syringes or not. We should be giving them new needle and syringes so that his next injection takes place with a clean needle and syringes, which is not contaminated with HIV virus or hepatitis virus. It could be A, B, C, but then most importantly, when we're talking about injecting drug using population, it is the Hep C virus. Then we also provide condom, because injecting drug using population does not mean that they don't get married. They are human being first, as I told you at the beginning of the session. Almost from the information of what we have collected across India, almost about 40 to 50% of the injecting drug using population out of that 1,77,000, they're married, they have their wife, they have their children. Then we have the clinic for particularly for STI and abscess management in the drop-in center. This clinic might not be there for other TIs like MSMTI, but then for an IDU TI, it is compulsory to have a clinic where a part-time doctor, when I say part-time doctor, a doctor who visits the drop-in center at least 3 times in a week, or it could be 4 times in a week, according to the convenience of the doctor or the negotiation with the NGO with the doctor of how many days he comes in a week and how long does he spend times in the drop-in center to address the STI. STI is sexually transmitted infection, and abscess management. Abscess is caused by injecting. When people do not inject properly, or when they are unhygienic about their practices, and when they don't know how to inject properly, abscess normally happens. So abscess management is an important component of the TI. Community mobilization, which is one of the most important component in all the TIs. So until and unless we do not mobilize the community, or we do not have the confidence of the community, it's difficult to implement the program in the community where we are actually working with. And referrals to HIV service. I've just written HIV service here, but then referral to any other needs. It could be TB, it could be ART, or it could be some other health need, or it could be some government programs where people are being provided with livelihood schemes and all those things. So this referral does not just limit to HIV service, but it is cross-cutting all the requirement. Methadone, I've already mentioned earlier that we have 5 centers across India. So if you look at the design of the harm reduction program in India, these are the tiers of harm reduction. The most important is outreach activity. Outreach is normally done by peer educator, and why we call it peer educator is we recruit active drug user, or people who are already on OST, or people who have actually kind of left injecting drug using population, but they know where the injecting drug users are, and it is easier for them to actually identify people and link them up to services. Second is the and in the outreach activity, we provide all those services: abscess management, needle syringe. That's the core activities, core service component in an outreach activity. And the second tier is the oral substitution therapy, which is a medication that is sublingual, kept under the tongue, and if the medication, the doses is provided correctly to the person who actually requires, who actually wants to leave drug use but then wants to come on OST. The most important part of this OST program is coming to the right doses of the particular individual. We could not generalize it by saying that we should be giving 4 mg to all the IDUs, or we should be giving 6 mg. No, it does not work that way. We have to look at the need of the individual person, of what kind of doses that he would require. It could be 4 milligram, it could be 6 milligram, it could be 8 milligram, it could be 10, it could be 12. It can go up. I have personally seen in Manipur where a person was actually taking about 32 milligram of buprenorphine. But those cases are exceptional. I'm not saying that we should go up to that high level, but then it depends on the individual requirement. And the third tier is the linkages service, which is very important because when we are talking about female injecting drug users, some of the female injecting drug users could be also involved in sex work. Um, there are injecting drug users who also comes from the MSM background. So we need to link it up to different services where it is available. So if an MSM walks into a IDU TI program, we should provide needle and syringes, but then as his behavior is different from injecting drug using population, we need to refer that particular MSM to the MSM TI so that that MSM has access to the services that is being provided by the TI from the MSM TI. So we have talked about generally the harm reduction component of the National AIDS Control Organization. Now I will touch a little bit upon the work that Alliance India is doing, which the project we call it Hirdaya. This is being implemented in yeah. This is implemented in at the moment in Bihar, Uttarakhand, and UP. And our program, what we actually do is we prioritize our implementation with injecting drug users to link them up with the ART program as well as scale up the OST program. So our priority is retention as well as scaling up of ART and OST among injecting drug using population. So this slide talks about the regional variation in HIV prevalence. So if you see Bihar, Uttarakhand, and UP, there are certain pockets that has also gone up to about 27%, which is kind of the highest among all the key population and also highest among all the other states. So I actually need not go through the whole slide. We have the concerns are Delhi and Rajasthan. Manipur and Mizoram is still there in the picture, but earlier, if you see or if you must have heard that injecting drug using population was more of the northeastern problem, but then it is not a northeastern problem anymore. It is spread all across the country. That's what I'm just trying to say from the slide. And again, it is of concern of various for all of us that the prevalence of IDU is actually not going down; it is increasing. So we need to collaborate more. We need to work more. And the main purpose of this presentation is, how all of us should be working together in collaborating our efforts. Yeah, collaborating our efforts so that we are able to arrest or we are able to control the epidemic among injecting drug users. Okay, touching upon the various kind of drugs that drug users in India they would prefer to use is if you look at the again the northeastern part of India, you would see most of them would prefer heroin. And if you look at the northern part of India, like UP, Delhi, some other surrounding states, The preferred choice of drugs is also brown sugar, but all across the country, besides 2 or 3 states in the Northeast, the major problem that we have in India is pharmaceutical drugs. For example, buprenorphine, pentajocin, spasmoproxybon, diazepam, Compos, nitrazepam, clonazepam, Avil, Phenargan. These are some of the the name of the drugs that has been listed, but they are more. So if you look at the people who are actually injecting across the country, majority of them would prefer to inject pharmaceutical drugs because of the easy availability, and it is actually cheaper if we do a comparison with heroin and brown sugar. So people would normally prefer to inject pharmaceutical drugs. And when I say pharmaceutical drugs, it is a combination of 3 or 4 drugs. But the main component of that 4 drugs, 3 or 4 drugs, it would be buprenorphine accompanied with Avil, Phenargan, or sometimes they also mix diazepam. So now here is the number of TIs that is functional at the moment, and if you see the third, fourth row where there is IDU written, the number actually has been fluctuating from 2010 till now, and 2012 and 13 was the peak time where we had the highest number of or the maximum number of IDU-TI in the country. It was almost touching 300. Now we have about 224 at the moment, and the various reason for this fluctuation of number is sometimes that when the evaluation happens, the TI do not pass the evaluation, so they are terminated. Some TIs they are discontinued. Some TIs they are not functioning properly. So that's why the fluctuation of this of the number. That's the reason why what I wanted to emphasize here on this particular presentation. So at the moment in 2016 and 17, we have about 224 IDU TI. But if we combine all the TIs of sex worker, IDU, MSM, transgender, we have about roughly 1,500 across the country. That includes migrants and truckers. So our our program actually complements the national program. Why I say this is because the services or the component that we are providing or we are working with the particular TI, it is an add-on services. Uh, I have already talked about 8 or 9 components that we are already providing, but then like we are enhancing those components, and we are also providing additional manpower to actually focus on sexual reproductive health for PWID and their partners. Legal right education is another important area where we have to educate the population that we work with, what is legal and what is illegal. Sometimes they could be arrested for no reason, but then like if they are educated about certain laws and laws that are implemented, they could also kind of defend themselves, but that's very rare. So that's why we need to have a lawyer who is actually kind of a legal advisor for a particular TI when people are arrested for no reason. So we need to kind of bail them out or take them out from the lockups or stop them from being sent to jail. Overdose prevention, education, and management. When we talk about overdose, it is not just about providing medication for the person who who encounter an overdose, but then like we also need to give them education to actually prevent overdose. Overdose normally happens when a person use multiple drugs, or a person use drugs with alcohol, have alcohol before and inject drugs. So sometimes when someone is high on alcohol, he is not able to kind of decide how much he needs to inject. So those are the incident where overdose actually happens. We provide education on hepatitis B and C, and also encourage people to go for testing. This is important for our colleagues who are actually from ICTC Center and ART, that people who injecting drug user who are actually coming to ICTC Center and ART, we also need to check if the facilities is available for hepatitis C infection, because most of the people in the recent time, from my experience, who are dying in spite of taking ART is because of Hep C complications. And Hep C, as most of the people who are attending the sessions are healthcare provider, ART, and also ART center, is a disease that actually affects or attacks the liver directly. Hep C is, in common term, it's more of a serious liver cirrhosis. So when someone's liver is not functioning properly, whenever he's taking ART, that also does not help or support that person much. And formation of peer support group, which is equally important for all key population across the country that we are working with. We need to form support groups so that they can support one another. It is not possible for an AIT center counselor or an ICTC center counselor to go out in the field and start looking for people who has actually dropped out or lost to follow from your program. So if we have support groups among people who are on ART or people who are actually coming to the OSC center, it becomes easier for us to actually look for that particular person when he or she is actually missing from the program. So please also try to encourage people who are coming to your center to form support groups so that they can help one another, they can support one another. So if you look at the diagram, our program is more community-centric program, and that's where I said the support group is important to have um, in all the TIs that are being implemented. Not only TIs, but then like also for ART, there could be injecting drug using population on ART. We could form a support group. It could be not necessarily a big number. It could be just 5. It could be just 10, so that they can support one another if they are on the medication. Okay, so yeah, implementing program is important, but then we also, side by side, we need to do advocacy as well as sensitization. Advocacy with law enforcement, because particularly for people who use drugs, the most important stakeholder is law enforcement, because there is a lot of arrests, and in order to decrease this arrest, we need to be constantly in touch with the law enforcement. Sensitization with healthcare providers, an ART center, ICTC center, TI needs to work in collaboration, needs to work closely, and consultation with relevant stakeholders to strengthen the programs in the state. There are various other religious groups, there are student groups, so we need to work with them. We need to make them understand what the program is all about. And national level dialogue with eminent stakeholders. When I am talking about national level dialogue, NACO comes under the Ministry of Health, but then we cannot just depend our program on Ministry of Health. We need to work with Ministry of Social Justice and Empowerment. We need to work with Ministry of Home. We need to work with women and child ministry. So there are various ministries that we need to work together. And for this advocacy and sensitization, um, the um, the strategy is to kind of conduct solidarity event. When I say solidarity event, it is the World AIDS Day, um, World Hepatitis Day, Human Rights Day, which was uh, very recent. 10th of December was the Human Rights Day. International Overdose Day, International Drug Use Day. So these are all events where we need to kind of organize these events together, so that we are able to sensitize the general public, we are able to sensitize the key stakeholders that we work with or that we are looking forward to working with. Yeah, OSD I've already talked about. So I think this is one of the most important slides for the audience who is here today. Why there is the prevalence of HIV among IDU is so high. Because number one, it is of sharing of needle and syringes and the paraphernalia. When I'm talking about paraphernalia, it is the injecting equipment that people use. It could be cotton, it could be water, it could be a container where people mix different kind of drugs. So it is not just about needle and syringes, but then if one needle and syringes is contaminated with HIV and Hep C, um, people can get infected from other injecting equipments, like sharing of water, sharing of cotton, sharing of cooker where people prepare drugs, unprotected sex, mainly penetrated under the influence of drugs or otherwise, selling of selling of sex to buy drugs. We have also come across people who actually sell sex to buy drugs, and this kind of incidents, like there is a high possibility of having protected sex, because the client would demand that I would not use condoms, but then the person who is actually needing money to buy drugs, he or she would normally agree to that, because they require money. Um, Passing on infection from sexual partner, from an IDU. Chances of vertical transmission. Vertical transmission is from mother to child. Um, as I've talked about, female drug users, there are many who are also married, who are, even if they are not married, they are involved in sex work sometimes, and they get pregnant and they also give birth. So, the vertical transmission happens. So it is actually from parent to uh, child or mother to child. Abscess, injuries during injecting, and overdose. Overdose is something which is important because it takes life. It is not just about passing on infection. A lot of people die of overdose, but then it is not being reported. STI, viral hepatitis B, C, tuberculosis. These are all connected with injecting drug use. These are all connected with HIV infection, and also the mental health. We have come across uh, people who have committed suicide because of their prolonged drug use. Okay, barriers for seeking healthcare services for PWID is, um, I hope some of the participants should not take this personally, but then we have come across many injecting drug users saying that we do not want to go to ICTC, or we do not want to go to ART center, because the doctor or the staff who is over there, they tell us that you first stop your drug use, then come back to ART. what I'm trying to say here is people can still continue to use drugs and also be on ART. The important thing for us here who are service providers for ART is that we must ensure that that viral load is at undetectable level. That's what is important actually. It's not about their drug use. And if it is undetectable, then there is very low chances of actually, passing on the infection. But then in the process, when they are coming to the ART medication, we should not be focusing more on their injecting behavior rather than we should be focusing more on their uptake of ART, whether they are taking ART on time, whether they have missed their doses, whether they are taking it regularly. So that is important for their behavior. We have TIs and counselors, so we should leave those responsibility to the TI as well as to the OSC center. But important thing is anyone who is infected with HIV and who are eligible for ART should be provided ART if should be provided ART whether they are a current user or they have stopped using. So that's the message that I wanted to actually share with the audience here today. Yeah, I would not want to go much into the detail about why people do not come to the ART center, but then these are something a common problem all across the country that the ART center is far away from the place where it is located, but then the government has been also trying to address with various other initiatives like link ART centers you know and also when an injecting drug user come to an ART center, and they would be very restless over there because of various reasons. They could be going through withdrawal. They can come very easily irritated. So these are some of the behaviors for the ART counselors that we need to understand, that if an injecting drug using population or an injecting drug user come to the ART, please try to. I'm not saying that you should be given the privilege, but then try to also address to them as soon as possible, because once they feel that this is not the right place to come and their needs are not addressed, it is very unlikely that they would come for the second time. And it's difficult for the TI people to actually address this. So, uh, the most highly recommended combinations of treatment is it is best for people who are on OST to be linked with the ART, and if he is found positive to be hepatitis C, link them to hep C treatment, so that like all treatment could be provided at one time. OST is a very good treatment because people need to take this OST medication on a daily basis, and most of these medications are directly observed treatment. So we can actually start building in their behavior that when they are taking OST, that should be the time that they should take ART. So automatically when someone is taking OST, after half an hour he can take ART. That way, like we don't have to actually monitor them, and it's a good education because OST also works very well with the injecting drug using population. And from a couple of studies of what we have seen across the country, that ART is most effective with injecting drug user population or IDUs when they are particularly on OST. So we should be looking at try to link it up with the OSC center, and if it is in the same government hospital, nothing better than that, so that you could have a coordination between the OSC center and the ART center. Yeah, I think this slide we have already, one of my colleagues have already talked about earlier, stigma and discrimination at the healthcare center. I need not put more emphasis here on this. But this slide is important for you. I think you should download this slide and also try to understand of why there is an enhanced exposure for PWID to get, more chance of getting infected with HIV as well as with Hep C. Why I'm because I understand that the National AIDS Control Program focuses more on HIV, and it is a HIV program that we are working with. But then the important thing is if we do not address hepatitis C, it becomes our program is not complete. But and again, NACO is also working something on the guideline to bring in hepatitis C treatment in the national program. So if you look at this slide, there are also mental health problems among many injecting drug users. So we also need to address mental health when they are coming to our centers for ART. And it's not that you have to spend half an hour or 1 hour time, but then it just could be about 5 or 10 minutes just to talk about mental health. And for an experienced counselor or a doctor, you could easily identify when someone is having problem, because from the body language or from their facial expression, it is easier for the healthcare provider to uh, address the mental health. Yeah. So these are some of the expectations from us as well as from the key population that we work with, that we need to reduce the HIV risk. As a matter of fact, we need to also look at the rights of the people who are coming into our services. That we are not doing a charity, but then it is people's right to have access to ART. It is people's rights to have access to HIV testing. It is people's rights to have access to hepatitis C testing or treatment. Um, Stigma should be minimum at all across the service center, not just AIT, but then I'm talking about general hospitals or any other place where services are being provided. We should be also looking at demand reduction. We should, if people are, if IDUs who are on ART are wanting to give up their drug use, we should be able to refer them to rehabilitation center or detox center, where you will have this information. You can get it from the TI. Mental health support, I have already talked about. Then facilities to access social security and prevent exploitation. I have already mentioned about the various schemes that have been provided by government. So we should be able to link them up so that they also have a livelihood scheme, even if they are using drugs. And for healthcare provider, one important message that I wanted to share with you is the needle prick injury is the most common needle injury that happens to actually a nurse or a healthcare provider in the hospital. So when you are dealing with injecting drug using population, be very careful about the needle or syringes that has been used, so that you don't try to recap it, but then try. I don't have to dwell much into this because you guys already know. But when you are dealing with injecting drug using population, deal with them as kind of a normal person, so that stigma and discrimination, that those signs are not there. So uh, when you are injecting medication for injecting drug user, you just act normally. Don't kind of try to act differently, because if you try to do that, then people normally you usually get offended, saying that, oh, I'm an injecting drug user, that's why you're not treating me well. And there are many female injecting drug users who do not actually come and access service. So it is our responsibility to also speak to people who come to our centers, that if you know any female injecting drug using population, please refer it to us. Please refer it to ICTC, AIT, so that they get tested. And if they are found positive, they should be on treatment as soon as possible. And as our society, our culture is such that, like, females are not given the power to have direct access to medical care or to direct access to targeted intervention. So we should be focusing um, on female injecting drug users. In Delhi, there are certain places that I know of, and many of my colleagues know of. But then they do not come to they do not come to our service because of fear, because of stigma, because of discrimination. So that's all that I wanted to talk about on injecting drug using population or IDUs. So if there are any questions, any clarification, any queries that you would want to know of, please feel free. I'm open for question and answer now. Okay. Um, Hepatitis C is, yeah, this is a question from VHS Chennai. Hepatitis C is a virus that is a very potent virus, and if we talk from a technical point of view, I'm not a doctor, but I've heard many of our doctors saying that it is 10 times more potential than getting infected from HIV. And the virus of hepatitis C can live longer in the contaminated needle and syringes. Not contaminated needle syringes, but also I have talked about the injecting paraphernalia or the injecting equipments like cotton, water, the cooker where normally people prepare drugs. So it can also be infected from there if one of the syringes or needle is or infected with Hep C.
Thank you, sir, for this comprehensive and informative session. Thanks to all the participants for patient listening. I request all the participants to kindly enter the questions which will be displayed on the screen shortly.